Hello, friends. So we all work in ICU, and we many of the time come across cases bleeding massively. It could be the post-op cases or post-trauma, or maybe a liver failure patient or a GI bleed patient. So invariably, what we do all do is we end up giving lots of blood products, and without realizing what actually is required. So to understand all this, what is required, and how to study it, and how to find out what is required, and so that we should be giving the specific treatment, is the role of Rotem comes in ICU. I am Dr. Bharat Jagyasi, Director of Critical Care Department, Kokilaben, Dhirubhai, Ambani Hospital, Navi, Mumbai, and we are going to talk today about the role of Rotem in ICU. So if you look into this, bleeding and coagulopathy in critical care environments can be a source of significant morbidity and mortality. And it's a quite complex thing, and exposure to giving allogenic blood products carry important associated morbidity. So we obviously need to avoid this. And if we look into it, there has been chronic disease, and especially when if involved with the hemostasis involved organs like the liver, kidney, or maybe the bone marrow. So invariably, the patient comes either with the bleeding coagulopathy disorders or maybe the bleeding heavily. And these are the patients where we really need to find out what exactly is deficient and how we should be correcting it. Or we might come across in acute settings in patient of trauma, blood loss, or some heparin has been given, maybe the patient was on warfarin and now bleeding massively. So these are the situations we need to find out and intervene in those situations and correct it appropriately rather than just blindly giving the product. So this is what we are looking to targeted treatment of bleeding events. So during acute bleeding, a multitude of different therapeutic options are at disposition of the physicians. And what we all end up doing is just giving any of the medication because it's very difficult to choose the right medication at the right time. The reason being is it's difficult to evaluate what is actually required and what should be the exact therapeutic option. And only right therapy will stop the bleeding. Supposedly, if you look into this, in liver failure patient, INR is always high. So INR was high, maybe was at somewhere around 3, and the patient ends up in ICU. Invariably, will try to correct that INR. But INR was actually invented to look into the therapeutic requirement of warfarin treatment. It was not at all invented to look into the bleeding risk of the patient, and it has very is not the only indicator which look into the bleeding risk of the patient. So just by giving FFP and when especially the patient required a platelets will not correct our problem, and this is why we need to find out what exactly is required by the patient, especially in conditions like liver failure, sepsis, trauma, or the transfusion themselves, and we need to evaluate, find out the strategies and evaluate to correct coagulopathy as are evolving. And one such strategy has been the increasing use of TEG and Rotem in ICU. So these are collectively called as viscoelastic assay. So viscoelastic assays include rotational thromboelastography and thromboelastography and have become increasingly available at larger centers. While two assays differ slightly in the execution, the overall therapy is about the same. So they were first used in OR during the transplant and cardiac bypass, and viscoelastic assays are also used at the point of care to help guide blood product administration. And more recently, they're also being used when large amount of blood products are required for resuscitation and also optimization of extracorporeal life support circuits. So this is what it actually does. Blood sits in a conical vial and is exposed to an activator at which point of tension or rotation element, which could be an either pin or a wire, estimates the clot strength as the time passes. Both assays plot a graph of clot strength, that is amplitude versus time, and this is what tells about the Rotem. So when the Rotem graph comes to us, it looks like an ECG. So as by looking at the ECG, we can actually make out what is wrong with the patient, which side of the or which artery is involved. So by looking at the Rotem, if we do it very often, just by looking at the picture, you can make out what exactly is wrong with the patient. So Rotem principle is simple. A sample is placed in cuvette and a cylindrical pin is immersed. Between the pin and cuvette, there is a gap of around 1 millimeter, which is bridged by blood or blood clot. Pin is rotated by spring alternating to the right and left. Now the blood is in liquid form, movement is unrestricted. As soon as the blood starts clotting, there's a restriction to the rotation of the pin, increasing with the rising of clot formness. And this is why rotation of pin is inversely proportional to the clot formness. And if you look at this, there's a light source. So rotation of the pin is detected optically and is integrated to the computer, which calculates the Rotem curve as well as the numerical parameters. So this is what the Rotem assays look like. So these are the various type of assays. Actually, there are 5 assays. So these are created when by adding different reagent to a sample. So extem is when we are looking into the extrinsic pathway. Intem is when we are looking into the intrinsic pathway. Fiftem is when we are looking into the role of or involvement of the fibrinogen in the clot formation. Heptem is when there is a heparinized sample and we need to reverse the action of heparin and we want to study the sample without heparin section. What is missing over is aptum, which also looks into the fibrinolysis. So there are 5 assays in all what we look into, and these assays are created by adding different reagents to the blood sample. So eventually, what we look into is this graph. So if we understand the concept of Rotem, what we are looking into is how fast the clot is being formed, how strong the clot is being formed, and how long does it last. So fast, strong, and last. So looking into the formation of clot, what we look into is the CT, that is clotting time. So this is line in green is what looks into the clotting time. So in extem, clotting time is less than 100 seconds, and in intem, clotting time is less than 250 seconds. So supposedly clotting time is more than 100 seconds in extem and more than 250 seconds in intem. It tells us that there is a deficient either in the patient either needs a FFP or the prothrombin complex concentrate. Now we are looking. This was about how fast the clot is being formed. Now what we have to look into how strong the clot is. So we look into the amplitude at 10 minutes after the clot formation, that is A10. So A10 in both the intem and extem is less than 40. If it is more than 40, it tells us clot is not formed that strong. So either, if you all remember, formation of the clot, the strength of the clot is by the platelets along with the fibrinogen. So either the fibrinogen is missing or the platelets are missing. And if we run that sample in the fifth time, and if the A10 is also more than 14 fifth time as well, or less than 14 fifth time as well, that means fibrinogen is missing, and that patient needs a cryoprecipitate or the fibrinogen concentrate. Now, ML is about the maximum lysis. So there's something called as maximum clot formness and the maximum lysis. So we look into the relation of it. That is the maximum lysis in relation with the maximum clot formness. So if it's more than 15%, that means there's a hyperfibrinolysis, and those are the set of the patient that will require the tranexamic acid. So these are the various parameters what we look into most commonly: clotting time, clot formation time, maximum clot formness, and maximum lysis. So this was about how fast, how strong, and how long it. If you can understand all this, I'm going to repeat it once again. The overall concept of the Rotem and tag becomes quite clear. So again, this is about how fast we discuss about. So it is about the green line over here. So that is called as clotting time. So this time it takes a new clot to begin forming, indicates the cumulative function of the higher clotting factors within the coagulation cascade, leading to conversion of prothrombin to thrombin. The moment clot starts forming, that means there's a conversion of prothrombin to thrombin. So prolonged clotting time can be treated with a FFP or the prothrombin complex concentrate. That means there's either a definition of these factors. So when we look into this, as I told you, in the extem, value should be less than 100 second, and in the intem, value should be less than 250 second. If it's more than 100 in extem and more than 250 in intem, that means there is a missing FFP or the prothrombin complex concentrate, and which should be given. Now we come to the next parameter, how strong. Again, we discuss this. Clot is composed of platelet plug along with the fibrins. So either the fibrin is missing or the clot is missing. So or the platelets are missing. So what we exactly do is we run A10 in a patient, and suppose A10 is less than 40. That means clot strength is not there. So either the platelets are missing or the fibrinogen is missing. We run the same sample in 510 and we read the A10 in 510. If the A10 in 510 is weak, then we end up giving fibrinogen concentrate or the cryoprecipitate. If the A10 in 510 is normal, that means this patient lacks platelets and these patients require platelets. So in those cases, platelets can be given in those patients. But there are certain cases where both the fibrin and platelets may be deficient. In order to detect those combination, there is the interference test which has been used. So suppose I've used an intem and A10 is less, I give fibrinogen first. Again, I run the sample. And again, if the A10 is less, then I end up giving platelets in those certain cases of patients. What we in the end look into is whether the clot which is being formed is durable. as it should be, and it should not be breaking down sooner than it should be. So this is a question of fibrinolysis, and it is being indicated by the maximum lysis. So this process occurs normally in healthy patients. For overactive plasmin causes hyperfibrinolysis, which is treatable form of coagulopathy. And to detect hyperfibrinolysis, you may examine lysis index at 30 minutes or the ratio of maximum lysis to the maximum clot formation. And your patients' clots are being lysed too early, and this is where you may treat them with a tranexamic acid. So this is very different in relation to the CRASH-2 trial, because CRASH-2 trial advises us to use tranexamic acid within 3 hours of the trauma. So this is not related to death. So this is not related to death. This is a different terminology altogether. This is we are actually studying in a patient. These are the hyperfibrinolytic patients where it can be used beyond the 3 hours as well. So again, for Rotem, initially we see how fast, that is CT prolonged, indicating delayed clot formation. Yes, then you give FFT or PCC. If it is normal, then you look into the MCF. If that is too weak or low, indicating a weak clot, then check for the 5-time MCF or Rotem platelet if available. If 5-time MCF is low, there's a deficiency of fibrinogen, give cryoprecipitate. If 5-time MCF is normal, then platelet is low, please give platelets in certain patients. Suppose if these two indicators are normal, even CT was normal and the MCF was normal too, so we have to look into the clot lysis. If the clot lysis is there, if lysis index at 30 minutes is too high, indicating too much of lysis, then please give tranexamic acid to those patients, because those are the cases of hyperfibrinolysis. So when to reach for the Rotem, we have studied this. Patients who require a massive transfusion, operating room, unclear bleeding causes in ICU, patients of GI bleed, or pre-operative optimization of liver patient. Also, if we need to optimize extracorporeal life support circuits. But Rotem has its own limitation. Clinical judgment should always be based on in combination with the Rotem. Rotem has never been shown to improve mortality. So mortality benefit is not there in all of the studies. Rotem doesn't have ability to detect anemia and to tell us about the need of PRBC transfusion. Low hemoglobin level can falsely increase Rotem amplitudes. Data for Rotem used with direct oral anticoagulants remains lacking. Data is limited to thrombophilia factor 5 lead and antithrombin 3 deficiency and detection of protein C and protein S deficiency. So again, I revise that. Rotem will not tell you about the platelet function disorders such as von Willebrand disease or Bernard-Solier syndrome. Factor deficiencies, it might tell you deficiency in the intrinsic and extrinsic pathway, but for example, it might not tell you to differentiate between deficiency in factor 8 and a deficiency in factor 9. Fibrinolysis can provide some information on the fibrinolysis or the breakdown of the clot, but it may not be able to detect abnormality in the process. So about the guidelines, these are the various societies, like European Society of Anesthesiology and European Society of Intensive Care Medicine in 2019 came up with a joint guidelines about the use of Rotem in perioperative and critical care settings. And this is where they suggest that Rotem should be used to guide transfusion therapy, and healthcare workers should receive proper training and education in the use of Rotem. International Society of Thrombosis and Hemostasis in 2018 also suggested the same thing in the critically ill patient. The same was also suggested by the American Society of Anesthesiologists in 2010, that Rotem should be used especially in the bleeding patient, and transfusion therapy should be guided by the Rotem, and we should also train our healthcare workers in the Rotem therapy. So these are the simple examples I have given, again on the same concept, that is how fast, how strong, and how long. So this was a 56-year-old male which presented to ICU with severe sepsis and disseminated DIC. Rotem was performed and released. It's not CF, it's a prolonged CT, that is prolonged clotting time, and decreased alpha angle, which is also seen in the tech. It was suggestive of coagulopathy. So obviously, if the clotting time was prolonged, we end up giving fresh frozen plasma and cryoprecipitate to this patient, and patient improved over 24 hours. Then again, one more example, in a liver transplant patient which experienced severe bleeding post-operatively, we did a Rotem, and really it revealed high lysis 30, that is high lysis index at 30 minutes and low clot strength. So obviously this patient has a hyperfibrinolysis and was given tranexamic acid and apratonin, and Rotem values improve over the next 24 hours. One more example of atrial fibrillation anticoagulation therapy patient was on, present to the ED, and CT revealed a subdural hematoma. After evacuation, patient was bleeding. So Rotem was performed prior to surgery and revealed prolonged R time and decreased MA suggestive of anticoagulation defect. That means this patient was given heparin. So the protamine sulfate was given to reverse the anticoagulation, and this Rotem values improves postoperatively. So Rotem is a viscoelastic assay which can be used in various situations like large-scale blood transfusion, unexplained bleeding episodes, pre, peri, and post-op courses of liver and cardiothoracic surgery, but may not screen for an illness. Use with caution when trying to manage or diagnose conditions like hemophilia or anticoagulation because of the DOACs. Rotem only helps you to strategify and to help you get through waveforms and parameter. Hematological experts may not be able to help you here for nitty and gritty breakdown and some help with strategy. So it's very important to understand the Rotem. It's not easy, but once you understand the concept, it will definitely help you in guiding the therapy. Thank you very much.